Good evening, everyone. My name is Mary Lou Cameron. I'm the Bilingual Program Support Manager at Bladder Cancer Canada. Thank you so much for joining us this evening for our webinar, Bladder Cancer Recovery, How Physiotherapy Can Help Your Healing Journey. During the session, we will address the benefits of physiotherapy and how it can apply to your bladder cancer recovery. We'll also move on to a short Q&A session after the presentation. Honored to introduce our speaker for the evening, Dr. Ana Maria Rodriguez Leboeuf. Dr. Rodriguez Leboeuf is a course lecturer at McGill University here in Montreal. She's passionate about and dedicated to the identification of unfulfilled needs of people with cancer, the development of rehabilitation programs for this patient population, and the development of self-care programs using modern methods for patients and for caregivers. Thank you so much for being here with us, Dr. Rodriguez Leboeuf. I'll pass the microphone over to you.
All right, thanks a lot. All right. So, what I've decided to present was perhaps a bit of a cap of a lecture that I've been given now for 15 years almost at McGill University that is targeting future physical therapists and also occupational therapists. We also have a few medics who attend primarily from a palliative care program. And so they're all introduced to rehabilitation. And I decided to take a few topics to demonstrate how rehabilitation and as well physical therapy in particular can help people who are undergoing a journey with cancer during active treatments for cancer and after after the treatment is over. And so I have a few objectives today, and this is what I'm going to focus on. There's quite a few slides, but there are some that I will pass a little bit faster on. However, I felt that it was important to share some of the information that we also share with our future clinicians to understand the need of cancer rehabilitation. So a first introduction will be understanding the impact of not only having bladder cancer on the body, but particularly the impact of the treatment options, the medical treatments that are offered for people with cancer in general, not necessarily only bladder cancer. And then try to understand what cancer rehabilitation can offer to people who are undergoing a journey with bladder cancer in this case, and also identify for people with bladder cancer what are possible impairments due to primarily the treatments that are used, and what could be certain solutions that could help minimize those impairment and maximize functional status and the overall quality of life of patients with impairments. And so first, I don't want this to become too technical. However, I thought it would be useful to provide some information about what are those medical treatment options and what are those impact that you may have lived if you're undergoing active medical treatment for bladder cancer, and that your loved ones as well may be exposed to. And so first, you probably heard about the staging for cancer, and the staging, there's different staging systems depending on the type of cancer and whether it's a solid tumor, a hematological tumor. But the staging has two main purposes. One is a prognosis, and to be able to predict the course of the disease and how responsive the disease would be to a particular treatment. And also it helps provide some prognosis as well on what would be the impact of treatment options. So once we stage a cancer, we could provide some options for treatment decision making. And so it's a complex process that really depends on whether the tumor is located in an area that's easy to resect via surgery or not. And typically there's a combination of chemotherapy, radiotherapy, and more we have more modern treatments like biotherapy or immunotherapy that have a lot less toxic side effects on patients. And so there's all sorts of different, as well, newer treatment options that exist, and that depends on the genetic profile of a tumor. So there's inflammatory markers and genetic markers that also will determine, as well as with the staging, what is the best treatment option. And several options may be used. So why do I talk about this here? Well, because going through some of these treatments, even at a high level, so I won't dwell too much on these aspects, could help us understand mainly what are potential risks in engaging in rehabilitation. So I typically go over these more detailed approach when I try to sensitize future physiotherapists and occupational therapists about what are the potential risks or watchouts more than anything for patients to engage in physical activity and exercise. And one is the type of chemotherapy that a person has been exposed to during their treatment, and also at which stage of the chemo journey a person is. And so chemotherapy is a systemic treatment. Systemic means that it affects the whole body, right? And it has different objectives depending on the stage. Again, to cure, to shrink a tumor, to control the growth of a tumor, or to palliate. And it could be done in combination with other types of treatment. And this is when we refer to neoadjuvant or adjuvant therapy, depending on basically if it's given before the primary treatment. So for instance, to shrink, we say it's a neoadjuvant chemotherapy. It will shrink the tumor before the main treatment, which is the surgery. Or if it's the opposite, if it's adjuvant therapy, then it's given after the primary treatment. So for instance, the surgery would be the primary treatment, and then there's a chemotherapy that is given to perhaps eliminate some cells that may not have been identified during surgeries. So those are the different terminologies that are used, but chemotherapy is a method to treat cancer that is highly effective, and we have more and better chemotherapy options nowadays. However, it affects the whole body. If you're interested in understanding how the field of chemotherapy and the different chemotherapeutic agents have evolved, I highly recommend this book that's a winner of a Pulitzer Prize. And it's beautifully written and also quite humorous in some areas, but it really goes through the discovery of different chemotherapy. So if that's something that you would like to read, it's quite an interesting book. And so the action of chemotherapy and why it's so effective is because it interferes with cellular functions of dividing and non-dividing cells. And so it stops cell growth and induces cell death in these types of cells that are cancerous, for instance, and only a fraction of the tumor mass gets killed at each dose. This being said, it affects, so that's why we need several cycles, and we need to repeat several cycles. However, there's also a fraction of healthy cells that also get eliminated at each cycle. And so this is why there are some current side effects to chemotherapy, besides fatigue and nausea that are quite common to chemotherapy. There's all sorts of different side effects that are associated to different types of chemotherapeutic agents that are used. And so you could see here all the different side effects that a chemotherapeutic treatment can affect. And these are actually, you may have experienced these, your loved ones may have experienced these, and some of them are as well could be solved by physical therapy, or at least soothed a little bit with the help of chemotherapy. And so not everything, of course, but there are some aspects of the side effects of chemotherapy that could be controlled. There's also cautions, especially when engaging in rehabilitation, and these are effects of chemotherapies, of bone marrow suppression. So whether it's having low neutrophils, meaning that the person is immunocompromised and has a risk of infection, or having low platelets in the blood, which puts a person at risk of bleeding, or anemia, which is due to having a low red blood cells or hemoglobin in the blood, and then there is a risk of hypoxia. So during active treatment for chemotherapy, we used to say many years ago that it's better to not be active because of these effects. And certainly these are cautions to take. If someone has a risk of infection, it's not time to go to the gym or go swim in a swimming pool because there is a risk of infection. This being said, there are other activities that can be done in isolation or in a safe environment, and that allows a person to be active, to be physically active, and maintain their strength and endurance during the course of a treatment. So these are types of quite common side effects that are controlled for quite closely during active treatment. There are some other side effects that are perhaps a little bit less known and associated with certain chemotherapeutic agents. And so one, for instance, is cardiomyopathy, which is basically having a cardiac toxicity. And it's less common for the treatments of bladder cancer, but it's typically associated to a type of chemo drug that we call and tricyclines. And so during the course of the treatment, so acutely, for instance, during the early exposure to the treatment, typically there is some control by the oncology team. However, if there is a heart disease already that is underlying, or people of older age, females for some reasons, and or having had the prior irradiation, could increase a predictor of having cardiac toxicity either during or after the treatment. So as I said, acute toxicity is typically quite well controlled. Resolves typically in a week. Subacute toxicity is typically treated as well with the oncology team by some drugs, beta blockers in particular, and the toxicity that may be a little bit more difficult to identify. Late toxicity can happen up to 5 years or even a decade after. And so this is where engaging in exercise and physical activity has to be done with caution, right? So there are now, of course, we know about this potential long-term effect of certain anthracyclines. So it's a bit better controlled, and we do sensitize patients to this potential risk. But this is why engaging in physical activity after being exposed to anthracyclines, in particular, if there has been a combination with radiotherapy, for instance, is something to be at least not worried about, but the different cardiac uh, basically markers need to be at least followed initially when engaging in physical activity. There's also pulmonary toxicity that could be typically is associated with bleomycin. And basically it could produce non-productive cough, dyspnea, pleuritic or substernal chest pain, fever, tachypnea, rales. So all sorts of pulmonary symptoms. And again, these are side effects that are quite well known and typically controlled acutely. And it's rare that it becomes chronic. However, it's something to also look for when someone has taken bleomycin. Finally, perhaps one that is more common as well, in particular for bladder cancer, is the use of cisplatin. And cisplatin causes often peripheral neuropathy, which is basically feeling pins and needles in the fingers in particular, in the feet. And it could even affect what we call proprioception, which is your body's ability to know where your body is in space, and therefore, it could affect balance, could affect walking in very severe cases. And we have, of course, many patients who claim that they can't touch anything cold, for instance. So a can of Coke, for instance, could be painful because of the neuropathy. And so there's different tricks and education that we give to patients in these instances. One is, for instance, using gloves to try to help us feel a little bit better what you want to hold, and as well to prevent uh, uh, touching very cold or very hot objects, which could increase the sensation of pain. So this is after it's up to 30% of patients who are affected by neuropathy when being exposed to cisplatin. And in some cases, it can persist even after therapy is discontinued once a person is healed of the cancer. So there are solutions for treating neuropathy with physical therapy, and I'll go through those in a few minutes. Finally, we have here radiation therapy, and this is a local treatment, and so it's also done to cure or to control or to palliate. However, I'll just go very quickly to say that the side effects of radiations are really dependent on the dose and the volume of the radiation. And there are some early and temporary side effects, but there are some late and often irreversible side effects. And again, it's local, so it's in the area where the beam of radiation has been exposing, or it's typically near the original tumor site, but it could cause neuropathies as well, fibrosis, and so at the radiation site. And again, all these side effects are local typically, but particularly if you receive radiation around the bladder, it could create some other side effects like nausea, vomiting, diarrhea, and perhaps sterility. So, and there's of course all these skin reactions that are associated with radiotherapy. And finally, there's surgery. I'm just going to skip this. We know that surgery could affect musculature, vasculature, neurological system, and lymphatic system. And this is where physical therapy can really help rehabilitate after a surgery. And we'll go through some details in a few minutes. Now, why do I talk about all of this? It's just to first is a note of caution to say that engaging in physical therapy, engaging in exercise is actually something that we strongly encourage now for many reasons. And I'll talk about what we call, at least in rehabilitation, exercise prescription. And what are the latest recommendations? There are some generic recommendations for people actively undergoing medical treatments for cancers and also for survivors. So it's something that is strongly recommended. There's even now some evidence, it's actually a Canadian clinical trial, that in colorectal cancer, for instance, it even increases survival of patients with colorectal cancer. And so that this was published just a month or two ago, and it's creating quite a lot of excitement. So why would it increase survival? And I'll go through some of the details, but maybe one way as well is to talk about this other classification system that is often used, and it's the patient performance statuses. There's two main tools that are used. One, it's called the Eastern Cooperative Oncology Group, which if you look at the staging, it goes from 0 to 5, and it really describes how independent a person is in everyday activity. So if a person is ambulatory or not, or needs care. And the one that's often used is also the Karnofsky Performance Status Scale, which is a bit more detailed, but still we're talking about a person's level of autonomy. These classifications are also used to determine the type of treatment that someone will receive. So the stronger a person is, they may also be receiving stronger doses of chemotherapy, for instance, or other treatments, which may also contribute to better survival. The systematic literature review really focused on activity and physical activity, not necessarily in the impact of being more functional in receiving, for instance, higher doses of treatment. But we also know that a stronger a person is, and the more independent that they can remain during the course of the treatment, that they will also receive potentially a bit more aggressive treatments, which have a higher chance of success. So there is a need for cancer rehabilitation, and cancer rehabilitation is defined as helping a person with cancer achieve maximum physical, social, psychological, and vocational function within the limits imposed by the disease and along the treatment continuum for cancer, which, as we have seen, is quite complex. And so one of the complexity of cancer rehabilitation, and why and basically I've really have been passionate about continuing to work in cancer rehabilitation, is that we have this example of a study conducted in 1978 where 805 patients with cancer were assessed for their needs for support by rehabilitation. And so these were random patients that were recruited from an oncology unit. And from these 805 patients, there were 52 with psychological issues. It's written in the 1978 terminologies. 35 had generalized weakness, 30 had problems with activities of daily living, 25% had difficulties with ambulation, 7% had difficulties transferring, which we mean by transfer is like standing from a chair or going from a chair to a bed, for instance. And even 7 had deficits in communication. And so that was in 1978. And the most important gaps and barriers were identified as the lack of identification, primarily by the oncology team, of these problems, and the lack of appropriate referral by physicians and oncologists who were unfamiliar with the concept of rehabilitation. That was identified in 1978 as the primary barrier to optimal delivery to rehabilitation care. In 2011, the same study was repeated and the same findings, more or less, were detected. And so in 2011, poor detection of the problems faced by patients and the general lack of awareness of the role and potential benefits of rehab are the same barriers that were faced in 2011 and still in 2025. So there's a real gap in referrals of patients to oncology rehabilitation. Um, and in the context of bladder cancer as well, in pelvic floor rehabilitations. Now, patients more and more are demanding these type of services, and what makes cancer rehabilitation a little bit different is that their treatment options are continuously evolving. Cancer is probably one of the disease areas where there's more and more treatment options on the market every single year. So it requires maintenance of current knowledge of different types of cancer types, the different treatments, different side effects and cautions, as well as how it could affect a person and their level of disability. We also face an issue in oncology rehabilitation in the fact that one of the barriers is still lack of education of our healthcare professionals, in particularly in oncology rehabilitation. And so we need to have this education based on evidence and theory, and this is partly what we are doing at McGill University. And so we're also now defining cancer as a chronic disease, and therefore we're talking about millions of cancer survivors in North America, millions of patients who are cured and have many impairments and dysfunction and quality of life issues. And once they're cured from their cancer, the follow-up to oncologists doesn't necessarily address residual problems that are side effects of treatments as well. So for this, I'll go specifically for bladder cancer and talk a little bit about Pelvi-Perineal Re-Education. And so this is one of the types of treatments that we provide. So it's called, in other words, pelvic floor rehabilitation. And this is physiotherapy for pelvic floor and related structures. And it can be indicated after an intervention. And so it's multifunctional, and it addresses one of the three major functions of the pelvic outlet: the urinary function, which is certainly affected after bladder cancer; the ano-rectal function, which is also it can be affected due to surgery and or radiotherapy; and the sexual function that could also be affected. It also has a function in core stabilization, and also has both static and dynamic roles. And this is what rehabilitation and pelvic floor rehab in particular can help support patients with. So if we look, for instance, the urinary system, it supports the bladder neck, and there's the urinary sphincter that lies between layers of pelvic floor musculature. If there is relaxation of those muscles, it leads to micturition. I don't know, I did a typo here. And if there is a contraction, there's bladder inhibition, there's the sphincter closure, and basically a person stop urinating. So there are interventions, and one example in the context of bladder cancer is the bladder reservoir surgery, where part of the bowel tissue, typically the stoma, is surgically um, uh, basically is surgically rearranged to create a pouch that will act like a bladder. And so this is one of the surgeries that could lead to urinary dysfunction. A second type of treatment or surgery that could lead to, treatment, that could lead to urinary dysfunctions are radiation therapy in the pelvic region. So I spoke before that it is a local treatment, but there could be fibrosis, in this case as well, cystitis, irritation of the inner lining of the bladder, decreased bladder compliance, and basically that fibrosis could lead to a decreased elasticity and contractility of the pelvic floor musculature. And that could include the sphincter as well, that really controls that ability to be able to be continent or not. And so there could be urinary incontinence, there could be a sense of urgency or urgent continence. So there's also sexual dysfunction that could happen after radiation therapy, in particular in the pelvic region. And it's all related to this increased fibrosis of the tissue, such as a decreased elasticity of the vagina in particular, and contractility of the pelvic floor, which could lead to painful intercourse, decreased sexual pleasure. It could lead to painful intercourse for both men and women, and decreased frequency. And in men, if there is nerve damage, it could lead to erectile dysfunction. So finally, the digestive system can also be affected. And so particularly when you have an ano-rectal dysfunction, it could be due to surgery, structural alteration, evacuation difficulties. There could be incontinence as well. And radiation therapy in the pelvic region could lead again to this fibrosis, which is reducing that contractility and elasticity of the rectum, the pelvic floor, and anal sphincter. And so that creates anal incontinence, as well as diarrhea, urgency, or constipation. Now, what are the different solutions? And I'm just going to go very quickly over some of them. But one is education. And so education of how to control, for instance, urgencies or urinary incontinence. So there's different cognitive therapies that could be used to try to help as well with that, but also discussing the role of the pelvic floor in the pathology, the importance of pelvic floor exercise and trying to increase that strength, as well as functional counseling, and also understanding that the bladder needs time to readjust to a new reality of a new basically of a new bladder. And so it takes some time for the brain to understand the position for accumulation of urine, and for the need of functional contraction and urinating. And this is particularly the case for bladder reservoir surgery. So we often help ourselves with cognitive behavioral therapy to try to make that connection between the brain and the new bladder that's working completely differently than before. This is also for men. It's a dribble stop clamp, which could help to prevent urinary incontinence. And so there's also some tools like this that can be helpful. Now, I'm going to touch upon exercise prescription, and I don't want to get into the cliches because physiotherapy and rehabilitation in general is so much more than just exercise. But in the context of cancer rehabilitation, exercise and physical activity in general takes a particular importance. So there's all the pelvic floor rehabilitation, which helps with the contraction. So having stronger contractions of the pelvic floor, and that can help with urinary and anal incontinence. It could also help particularly with the contraction for sexual function. However, we also work with manual therapy to try to stretch tissues if the issue is that it's too fibrous, right? So we work with both increasing the contractibility and also increasing some of the flexibility of the tissues with manual therapy. Now, for exercise, we're talking about general exercise of the body. It varies depending on the goals of cancer rehabilitation. So if it's preventative, so where we can reduce the severity of the impairments and the side effects, as well as restorative. So when we could only have minimal or residual handicap, this again is wording from 1974. So here today we would say residual impairments or disability. Um, then we could be a little bit more aggressive in physical activities. Now, if it's supportive, so we know that the disability has to be, it's permanent and it has to be tolerated, then we may change the type or adapt the type of exercise that are conducted, as well as in palliative cases, which are really to maximize the level of function of people as much as possible. But we do know that there's positive effects of engaging in physical activity. And this has been shown with patients with cancer, both during medical treatment and following treatment. And it's particularly useful for fatigue, for potential depressive symptoms, for physiological outcomes, for the bone mineral density. So you may know that there's often some treatments that could affect the density of bones and lead to an early osteoporosis. So it helps with bone mineral density. It helps improve immune function. So even one of the common toxic side effects of chemo, and it overall improves quality of life. There's also before surgery, especially those that could be a bit more invasive, where prehabilitation could really improve the outcome of a surgery. So we can prepare ourselves to a surgery by engaging in rehabilitation before the surgery, which limits basically the impairments post-surgery. Now, we do know that physical activity prevents certain types of cancers. As I said before, one of the one of the way to stage the cancer and to therefore give access to different treatments is associated with the functional independence a person has. So, but we know that having better overall strength and overall conditioning improves the tolerance to cancer treatment, such as radiation and chemo, and therefore we could probably increase the dose a little bit, which then maximizes as well the chances for to have a longer period of time without needing chemotherapy. It reduces the risk of recurrence for certain cancer types, and we know that there's our improved mortality rates among cancer survivors. And that systematic literature review, this clinical trial that was conducted just has shown this again. Now, that has led in 2006 the Journal of Clinical Oncology to publish a whole fascicle that called out to the oncology clinical community to start saying to their patients that it's time to get moving. So whether before we were saying to patients to rest during their treatments for cancer, as well as perhaps after. Now we are saying to patients that they shouldn't be resting too much. We know that basically it increases survival and increases the overall ability to resist these aggressive treatments. Now that created both a positive and a negative, I would say, impact. Positive because patients are now engaging more and more in physical activity during their treatment, which just overall improves their health and quality of life. But one of the side effects is you saw all the different cautions, and this is why I started with this, of engaging in physical activity with the potential toxicity, having neuropathies or ataxia that could affect balance and therefore the safety of engaging in exercise. And there's sometimes increased risk of osteoporosis and metastases. And then the risks I said before that are typically associated with acute treatment, like bone marrow suppression. So this is why not everyone should be able to prescribe exercise to patients who are at least currently undergoing cancer medical treatment. Um, and that's why in physical therapy, we term it the exercise prescription, because it requires a quite in-depth knowledge of the type of chemotherapies a person has been exposed to, or radiotherapy, and the potential risk to watch out for when engaging in physical activity. And so, we just saw the unstable cardiovascular status. There's a possible risk for rapid oxygen desaturation, primarily for lung cancer patients, but it could happen as well, depending on the chemotherapy someone has been using, as we saw, and as well this increased fatigue, which are typically characterized by having low energy levels up to 24 hours after an activity, and needing to sleep or rest more, and as well very easily provoked sweating when engaging in exercise. And so that means that either the timing of the exercise is wrong, or that the amount of exercise is too aggressive. Now, timing is important. As we know, fatigue is one of the side effects, not only of the cancer, because of there is more inflammation in the body, right? So there's a more immune activity. But it's also, as we saw, a common side effect both of radiation therapy as well as chemotherapy. And therefore, timing the exercise with the expected peaks after being exposed to chemo and radiotherapy is very important to make sure that the peak after that is expected 2 or 3 days after chemo does not correspond to a heavily intense exercise session. And then there is one risk, which is typically more associated to advanced cancer. However, there is a possibility for what we call bone metastases. And in the context of bone metastases, um, there could be a risk of fracture if that metastasis is not detected. So this is why having medically trained personnel to provide guidance for this exercise is really important. I'll just skip this very quickly in the interest of time. I just showed two papers that, and I could share that as well with the association to share that there's now some precise guidelines. So there's a first paper that was published, I forget when it was, the year, I cannot see very well, but a guideline for exercising for people in cancer. And basically the main focus was, is it safe? And what's the level and intensity level and delivery models that are best? This being said, there was not a single physiotherapist involved in the study, so basically it's a recommendation by oncologists, but still it was determined that people living with cancer can safely engage in moderate amounts of physical activity. And basically the goal was 150 minutes of moderate intensity aerobic physical activity over 3, 4, 5 days, and resistance training at least 2 days per week was recommended. And they recommended as well group sessions over individual sessions. So that was some of the physical activity recommendations. And what was really interesting here, and I keep it here, and I always give it to my students, because there are some risks in engaging, right? We did talk about the platelets as well, having low white blood cells that could put you at risk. So it's important to know what are the reference ranges, and when are the considerations where perhaps we should withhold exercise when we know that our current day, for instance, neutrophils are low or platelets are low, or high, but typically is we're worried about the low side, as well as blood glucose. So it gives really good recommendations and cutoff scores, saying, maybe now is not the time to engage in exercise. So that's why I always keep it in, as well as potential caution regarding bone mets. So even people with bone mets can still exercise. It's just the type of movement that is needed or allowed if you want to try to reduce as much the stress on the bone, as well as the type of exercise needs to be cautionally monitored. There's a newest now guideline, so I've now remembered the year was 2018, and I think this one was in 2022, which are exercise guidelines for cancer survivors. So that's once the cancer is cured. And so the previous recommendations is during active treatment, and this is after treatment. So, and this was an international consensus. Physiotherapists were involved in those guidelines, and basically they provided a list of types of activities that one could engage. So if you're interested in any of these papers, I could share any of them, and they provided a review of what were the expected patient benefits from exercising. So I'll just finish and to leave you some times of for feedback and questions. So I discussed really before for the manual techniques that are provided in pelvic floor rehabilitation to facilitate that pelvic floor contraction and relaxation as well to improve proprioception so that that bladder that just received the surgery is able to now perceive well, for instance, when there is urine in the bladder and when it's time to evacuate. It also helps to mobilize muscle and soft tissue, desensitize areas, and decrease the pain in the area, especially if there's radiation therapy and fibrosis. So you can really work on reducing that fibrosis, normalizing muscle tone, and improve circulation. And so here we have an example of how that would look. And so indeed there is manual therapy in that area, but it's muscles and ligaments just like anywhere else in the body. So there's stretching of muscles, desensitization, connective tissue massage, and global techniques. And so it's quite effective as well, particularly when there's a fibrosis which is creating pain. There's also biofeedback methods where you could assess the contraction and receive right away some biofeedback to try to increase the contraction. And also for rectal incontinence, there's rectal balloon techniques that help to improve proprioceptive awareness, the increase comfort at distension, because that's sometimes often, especially when you have a fibrosed anus, it really can create pain as when there is that distension of the anus for defecation, and also for functional retraining. So this desensitization, response to distension, as I just mentioned, and simulated evacuation. So that's it. That's the conclusion of how we can improve quality of life in people with bladder cancer and how rehabilitation professionals have a crucial role to play in the field of oncology and unfortunately are not referred to on a routine basis. So if you, I'll open the floor for the last few minutes for questions.
Thank you so much, Dr. Rodriguez Leboeuf. Thank you. It's such an informative presentation, and I think everyone was super engaged as well. So if anyone has questions, please feel free to add them in the chat now, and I can read them out loud. We did have a couple of questions that came in during the registration as well. So I'll read one of those to get things started. But someone asked, are there exercises to avoid altogether if you have bladder cancer?
It's difficult to give a generic answer to this generic question. It I would say probably no. However, it really depends on, well, first, uh, several factors, as I just discussed. It depends, the type of medical treatments you received. Maybe there's something to avoid, or at least at the beginning, as we're monitoring the response from the cardiovascular system, for instance, or pulmonary function. So that depends really on the types of treatments that a person has received. And also if there are known risks. So if someone has bone metastases, for instance, as well as their bladder cancer, then yes, indeed, there's some certain movements that you want to avoid. There's also certain movement that may not be really comfortable, especially if someone just had a bladder surgery. So we're trying to avoid lying on prone, right, as we're um, as we're healing from that surgery. So we need to follow that recuperation process. However, yeah, there's different. I don't think in general we could say that there's any exercise that is not allowed. However, it's evaluated on a case by case basis depending on all the factors that I discussed. Certainly, someone with bone mets, there are exercises that are not allowed.
Yeah, thank you. And another question, particularly for consulting, actually, to do physiotherapy. If someone, that's had their bladder removed and they would like to do physical therapy afterwards, should they see a physiotherapist that's specialized in pelvic floor, or would there be any type of physiotherapist be appropriate in that case?
Uh, well, it depends what they're going for physiotherapy for, but if it's for incontinence, for instance, or any side effect after a bladder surgery, um, then yes, pelvic floor rehabilitation is the place to go. And they could probably also assess a lot of the disabilities that are remaining after the treatment. Now, if it's for other types of support, like we saw, overall deconditioning or increasing, strength, perhaps a certain proprioception, especially decreasing neuropathies and all of this, um, typically it's better to go to a specialist ideally in oncology rehabilitation because of all the risks and also the lack of overall education in cancer rehabilitation.
Thank you. Yes, and if anyone's interested in specifically some pelvic floor and abdominal strengthening, we did do a webinar a few months back. That's exercise demonstrations that are available in our Healthy Living Guidebook as well. So that video is available to do some demonstrations if that was the goal. One question here in the chat is if someone has lower energy, particularly due to immunotherapy treatments, are there particular exercises they can still do even though they're having those lower levels of energy?
Yeah, and actually, any cardiovascular exercise in particular, but also strengthening exercise will help improve that energy level, right? Because now the immunotherapy is affecting your energy level, but if you assume that your energy level is here currently and the immunotherapy brings it down like this, basically your maximum level of energy for a day is now at this level. If you have higher cardiorespiratory and strength, so better conditioning, your overall energy level is here. And even if the immunotherapy lowers your energy level, you're still not at your maximum level of energy. So you do have more resistance in terms of energy. So I would follow some of the guidance that the general guidance that were provided, not engaging in um, very very aggressive, I would say, treatment, but moderate aerobic exercise 3 to 5 times a week, as well as strengthening two to major muscle groups 2 to 3 times a week. Um, if there's no other risks or other chemotherapies that we're taking or radiotherapies, then in that case, it might be a little bit, there's less side effects, and therefore it can be done safely. If there are chemotherapies as well, in addition to the immunotherapy, it's something to check for whether you would need to be monitored. What is really important is just try to know when do you have that low energy the most? How many days after your treatment? Because you don't want to be doing exercise that day. You do it a little bit later. Just and again, what I gave as a guideline just before, if after engaging in physical activity for 24 hours, you're exhausted and you need to sleep more because of it, it's a sign, or pain increases for anything at all, then it's a sign that it's been too aggressive or not at the right time.
Thank you. Yeah, so as Dr. Rodriguez-Leboeuf said, but also, consulting and seeing for everyone's particular case will be different. So I think that's all we have on questions for now. So let me share my screen again. I'll move it here. Okay, hopefully everyone can see my screen now. So thank you so much to Dr. Rodriguez-Leboeuf for this wonderful presentation and also for answering our questions. It's so appreciated, and I know this is a topic that we get lots of questions about as well, so it's great to have this as a reference as well. We hope that everyone tonight enjoyed this session. We have two more upcoming webinars. So one will be on Tuesday, July 15th at 7 p.m. Eastern Time, covering aging, sex differences, and bladder cancer with Dr. Madhuri Koti. And then we'll be taking a short break for summer in August, but we will be back in September on Tuesday, September 30th, specifically at 7 p.m. Eastern Time as well, for a session on guiding your family through a cancer diagnosis. So, how to have healthy conversations and to set healthy personal boundaries as well. You can register for all these events on our website under patients/upcoming events, or you can scan the QR code that's available here on the screen that will take you right to that page. After this webinar, a survey will pop up in your browser as well. We would love to hear your thoughts on this session and suggestions for any future presentations. So please, if you have the chance, take a few minutes to complete the survey. We would really appreciate it. It will also come to you via email tomorrow through Zoom if ever you don't have the time to do it today. If you would like any accommodations to complete this survey, or if you have any additional questions or comments, you can always call us at 1-866-674-8889 or email us at info@bladdercancercanada.org. We'll be happy to speak with you there. A recording of this session will also be uploaded to our website in the upcoming weeks, so please be on the lookout for that. It will be on the website as well as our YouTube channel always. A little announcement, but Canada Walks for Bladder Cancer is celebrating 15 years this year, and we really hope that you'll be able to join us. For 15 years, participants and supporters have helped improve the lives of those affected by bladder cancer by raising over $3.2 million for research and support programs with the goal of improving outcomes for every bladder cancer patient. Support the work Bladder Cancer Canada does and help raise awareness of bladder cancer by getting it involved today. You can register, volunteer, or donate. It all makes a difference. So to learn more about this, please visit bccwalk.ca. Once again, a big thank you to Dr. Rodriguez-Leboeuf for a great session this evening, and thank you to everyone for attending. We will also have the French session tomorrow evening if anyone is interested in hearing in French first, and wishing you all a great evening. Thank you so much.